Hello, this is Dr. Hausinger, and this lecture is regarding Chapter 10 in your SAC book, Preventing Substance Abuse. Our learning objectives for this relatively short but important chapter are to summarize the 4 stages of substance abuse prevention implementation, define the 3 levels of prevention, contrast the abstinence and harm reduction approaches to substance abuse prevention, construct a causal model involving overindulgence of alcohol at a party, explain at least 6 issues involved in trying to change the prevalence of substance abuse problem behavior, illustrate 5 dimensions that should be considered in assessing the effectiveness of a prevention program, paraphrase mass media programs, economic controls, educational programs, and community peer-based programs in the context of substance abuse prevention, summarize the Center for Substance Abuse Prevention strategy. Okay, so we're looking at the concept of prevention, which was introduced to you in the previous chapter. Prevention refers to activities that reduce or stabilize the incidence or occurrence of new cases of substance abuse and thereby reduce or stabilize its prevalence, which are the total number of cases. While there has been widespread agreement that prevention is important, there has been a lack of agreement over the best way to achieve it. So there are a lot of different practical difficulties here, and a lot of that has to do with knowing when substance abuse starts, risk factors for different ethnicities, races, communities, socioeconomic status, etc. Part of this is also that there's been a debate over what should we be doing. Should we be pushing abstinence-only education as a rhetoric, or should we be looking at the reality that people are going to use regardless of what we do and looking at more harm reduction? So we need to understand the causal factors in the development of substance abuse, design programs and activities that modify these risk factors specific to those populations, obtain the resources necessary to implement our programs because they don't work unless they're implemented effectively and efficiency, and demonstrate the effectiveness of programs. Researchers have articulated an impressive array of risk factors for substance abuse. But a risk factor is not necessarily a causal factor. And if we look at risk factors, we can potentially decrease them by increasing protective factors. So we have to look at both of those. And there's also a difficulty with finding resources for substance use programs. Right. And those programs that have been implemented long-term don't always yield the results that we would like. And we could look at the Just Say No campaign and the DARE campaign. So there are community responses to substance use that Bourne has argued, and the first one is that we don't have a problem, another community has a problem, it's not there, we're a good community, blah, blah, blah. Okay, denial, right? We're familiar with that. The next thing that happens is there's panic, oh my gosh, what do we do? And that's when we sometimes get knee-jerk policy, which is sometimes more detrimental because of the unintended consequences that happen. And then we have fragmentation, which is where we have different goals and counter proposals. Some may be productive, some might not be. And then there might be a solution that's picked. And then the key characteristic, what happens here is that sometimes there is a regression here, and we go back to the panic and the denial. The key characteristic of the fragmentation stage is that the community response is based on considerations of cost, political clout, and ease of implementation rather than being a comprehensive, integrated approach to the prevention of substance use, misuse, and abuse. So again, we have that knee-jerk reality, that knee-jerk policy there. The researcher who came up with this indicated that relatively few communities progress beyond the fragmentation stage, and I think that we're really seeing that in our community right now, and by community I mean Western Washington. When existing programs no longer seem to be working, the typical community response is to divert increased resources to the existing providers or substance abuse services, and to add an additional program or two to satisfy perceived needs. Perceived needs. Eventually, what we want is several factors to combine to move a community from fragmentary to cohesive response. And those include looking at the increasing costs of supporting the existing programs, the persistence of substance abuse, and increasing community awareness of the inadequacies inherent in the ad hoc system. The cohesive stage of a community's response to substance abuse is typified by a comprehensive planning process. This planning process is based on a thorough needs assessment. So you're seeing this, I think you're seeing these stages, especially the fragmentation stage, when we talk about the Seattle is Dying documentary. That's where we're at. So you can actually see that the community is fragmented, and the knee-jerk response is we're going to lock up everybody and force people onto Suboxone or methadone or whatever they choose. And so it's a little misleading. We're going to involuntarily lock people up for being homeless and using drugs, but then they get to choose what type of treatment they have. Okay. All right. So it's important to be able to recognize inflammatory policy, and that's the fragmentation here. Okay. So there's different levels of prevention. In primary prevention, we're looking at activities that are designed to forestall the use of drugs. So just say no, refusal skills, scare tactics, mass media campaigns. In the secondary prevention stage, we're targeting experimenters and occasional users of drugs through early identification and intervention to prevent more serious drug use patterns or drug-related problems from developing. So there's a continuum here. Intervention and prevention are actually kind of like a snake that eats its own tail. It's a circle, and they can be one in the same. Our tertiary prevention parallels treatment efforts by focusing on ameliorating existing drug-related problems and preventing relapse. So this looks very similar to the stages of change. So we want to look at what is the purpose of prevention and what are we trying to prevent. Okay. Abstinence-only education often uses scare tactics or comparisons. We have the Meth Project that has very scary images on it and ads. Okay. There are programs that are trying to help people be educated for responsible use, and that might be like the drunk driving commercials and campaigns. It's very closely related to harm reduction. And then we have unintended effects. So abstinence might be a good goal, but it also could be a potentially harmful one as well. And your text goes on to talk about, substances have their places, excuse me, especially medicinally. And so I think you can see this with the Schedule 1, the DEA, we have marijuana as a Schedule 1, which is up there with heroin and meth. And so what type of message is that sending when marijuana is not very harmful when we're comparing drugs in terms of capture ratio, which is the number of people that are on the drugs, who get hooked on the drug, etc. Okay. Right. Each approach might have different unintended effects, and so when we're looking at prevention, it's important that we look at things holistically so as we don't have a fragmentation and that we don't have these knee-jerk policy, because that's often what happens. And I know that I've spoken about this before, but one of the main things that's really happening now is we're seeing people that are actual chronic pain patients. I'm not saying that heroin users are not chronic pain patients, because many of them are, but when we say, okay, doctors are going to be held liable now, and they can only write so many prescriptions, and if you had so many prescriptions for so long, you're getting kicked off your medication, I think that's akin to medical malpractice. And what we're having now is people committing suicide because they're actually in pain, and now they're just like, okay, we'll take an aspirin. That's not going to work. That's not going to work. Okay. Prevention programs can use reduction or harm reduction. So many people ask why programs are based on abstinence, and there are several reasons for this. First, there's a historical tradition that emphasizes non-use of drugs. Second, there's a simplified logic that specifies that if people don't use drugs, they can't abuse them. Okay. Third, a mystique and a mythology regarding the evils of drugs have developed. And I think that sometimes it's romanticized if we look at popular culture, superheroes. Look at Jessica Jones and Hancock, for example, when we're looking at superheroes / anti-heroes. They're dark and broody. They both have alcohol problems. They're mysterious and romantic, and there's this kind of, you know, darkened romanticism and mysticism around it. And so drug use is kind of like, oh, okay, well, they have a crutch, they have a deep soul problem, and they need to be changed by love. And we see this rhetoric in films and in books and TV. And I think a lot that's part of it. And then there's an emphasis on abstinence. It's easier to carry out than trying to define acceptable levels of controlled use. Okay, so achieving change in the prevalence of substance abuse or the consequences of abusing drugs depends on the development of a causal model. Such a model specifies the presumed antecedents of substance abuse, so factors that are subject to change and thereby reduce the occurrence of abuse can be identified. That's a fancy way of saying, how do we determine the cause of the use and the effects? Okay. So for example, your authors say that concern over drinking and driving generally focuses on either restricting drinking or identifying and punishing drivers who have been drinking. Restrictions on drinking are attempted through public education campaigns regarding the risks of drinking and driving. Identifying and punishing drunken drivers is a law enforcement concern. Although these approaches are needed, they are incomplete. Both approaches ignore the acute and chronic effect of alcohol on subjective perceptions and the lack of intent by many individuals to overuse alcohol and then drive. The authors state that we need to develop methods that will deter driving by intoxicated individuals, such as devices to keep the people from entering or starting their car. Okay. And they do have some of those. However, people can be really crafty, and there are ways to get around the blow and go, and so they started putting cameras in the blow and go. I also want to add that the United States has the highest tolerance for blood alcohol level. We're 0.08. Other European countries, well, we're not a European country, but you know what I mean. European countries and Asian countries usually go between 0 to 0.06. I think Sweden is 0.06, and a lot of places are 0.02. Japan is 0. If there's any alcohol in your system, it is an automatic year in prison with a $10,000 fine, and if you are a teacher, you'd lose your teacher's certification and you can't teach. Okay. In a lot of these countries, though, their public transportation is amazing, and many people don't have cars or don't have the need to have cars. Okay. So we really need to look at things holistically and comprehensively, and I think that we have a lot of these programs that are not fully well-rounded, partly because people don't want to admit that our precious sons and daughters and mothers and fathers could use things because it's demonized and stigmatized. And the second part of that is it is a lot of effort to have a really good program. Just saying don't do something is basically akin to a parent saying do as I say, not as I do. And so it's a lot of work to have a comprehensive approach. But if we look at it from a biopsychosocial perspective and have individual prevention programs for specific populations, then we're addressing things more holistically. Okay, so how do we make change? First, we have to have resources. And unfortunately, a lot of the mass media campaigns is really a byproduct of the war on drugs, especially if you believe the conspiracy theories that, our government brings in drugs or allows for corruption to occur, and other corrupt governments allow for this to occur. Again, do as I say, not as I do. It's difficult to get funding for this, and unfortunately, the United States has a history of cutting social programming whenever there's a budget crisis, and that's the exact opposite of what a lot of other countries do. If there's a crisis, countries pump money into feeding people and resources, and here we do the opposite, and we put it into war. Okay. So that's difficult. It's not impossible. In fact, if you look at some of the resources posted in this week's Moodle module, there are a lot of grants that are out there. You just need to apply for them. The absence of federal and state resources can be largely attributed to both an inconsistent social policy on prevention and an entrenched treatment orientation to substance abuse. Substance abuse prevention often overlaps with an array of other social and personal problems such as mental health, education, law enforcement, and healthcare. This overlap has resulted in competition among community agencies for funds, clients, and other resources. Although we are moving towards coordination and integration, This requires both social policy commitment and extensive staff training. And then we get into the debate about what type of education do we need for our counselors, how much is too much, how much is too little, etc. The other issue here is that we have really institutionalized the treatment system for substance abuse. Helping professionals are understandably more oriented toward services for afflicted individuals than toward preventative programs, which does seem counterintuitive. Okay. So we want to be careful of counter prevention. And that is the disagreement over the means and ends, right? So if we're spending all of our time arguing, and I do feel this might not be a popular opinion among all professionals, but I do feel that debating is addiction a disease or not, I think that's counterproductive. If we want to treat it like a disease, then let's treat it like a disease and have doctors treat it, have more educational requirements, have more time, etc., expand types of treatment, have more medical, clinical, behavioral health than some of these made up treatments that we see that don't work, because it is very much a business. Okay? So I think that sometimes the debate over addiction is a disease versus it's not is counterproductive. Not everybody is going to feel that way. Okay? And in many ways, saying addiction is a disease was helpful medically. But, we've talked about the debate on that. So again, I think this is illustrating the point of counter-prevention. Okay. Your text argues that the main programs that we have, anti-smoking programs that started around 1964 and seatbelt campaigns around 1972, they've been around for a really long time. So it takes a long time to do this. And last week you watched the Australian drunk driving PSA that's been around for 30 or 40 years. It took that long to have a lasting impact. So it takes a long time. And a lot of your evidence-based treatments, empirical-based treatments, if you look at the ADAI clearinghouse for the screening tools that were posted early on in the semester, a lot of those screening tools and alcohol assessments, a lot of those were developed in the 80s, and it took that long for them to be legitimized by science that, yes, these do work. So it takes time. So this is another problem that we have with knee-jerk policy. Okay. And then what is the intensity? So in addition to allowing enough time for prevention to work, we must provide programs of sufficient intensity to make changes occur. The intensity of a program is particularly important when we examine school programs, but should also be considered when designing other prevention activities as well. So they're arguing here that lots of times they just pop in a video or it's talked about once, whereas it's not integrated into our education system and culture. So if you think about if you have children or siblings, or if you were a child at one point, how many times do you have to be told to do something like wash your hands before you eat or after you go to the bathroom, put your shoes away, don't leave toys on the stairs? Like, we have to be told things many, many times over a course of many years for things to really sink in. It's not just a one-shot deal. So that's part of this too. How can we set up prevention so that it becomes a part of our education? And then how do we evaluate programs? So we have to have a positive balance. Right? This is located on page 248. So we have to look at financial costs. And these include billions of dollars spent by the federal, state, and local governments on law enforcement, and things like lost wages, health problems, hospital bills, etc., property damage. We have to look at criminal justice problems, including the number of personnel diverted from other law enforcement areas. It's hard to enforce a victimless crime, possible corruption of officers, prosecutors, and judges, and hostility and alienation of community members who oppose different approaches, increased health risks for users from the poor quality control of street drugs and from the spread of diseases, increased criminal activity in the form of black market supply to the drugs and the need to acquire the money to purchase drugs, and perpetuation of myths about drugs and drug use because of the difficulties in studying illegal activity. So it is challenging to figure out how does it work. So a program has a positive balance when its positive effects outweigh its negative effects. And that can be something that's difficult to track measure, and authenticate. Right. An example of the importance of positive balance is found in the law enforcement approach to the control of substance abuse. The underlying logic of this approach seems to be that by reducing the availability of supply of drugs through legal restrictions on the importation, manufacture, distribution, and sale of drugs, and by reducing the demand for drugs through imprisoning or deterring users and dealers, we can reduce the prevalence of substance use and abuse. It's often argued that reductions in the prevalence of substances will result in a reduction in drug-related crime. Okay. Finally, a corollary of this approach contends that if legal restrictions are initially ineffective, we need to strengthen the penalties for noncompliance. Okay. However, the concept of positive balance calls into question the efficacy of drug laws and their drug enforcement and preventing substance abuse. So we know that some communities are much more adept at this than others. Okay. So again, and we hate saying in social work, well, it just depends, but it really does. Everything is exceptionally subjective. Okay. So we have to really make sure that we're being specific. And that brings us to targeting populations. So general prevention program is one that's applicable to a large array of individuals, regardless of the degree of involvement in substance use and abuse. Specific prevention programs focus on certain groups with the specificity defined in terms of a presumed or empirically validated common characteristic. So for example, drug information programs, they're general because they enhance knowledge of how drugs affect behavior. Specific information programs have been developed that target the drug use and abuse problems among specific populations. For example, Black Americans, Native Americans, older Americans, and Hispanic Americans, because they all have very different use patterns. Okay, that makes sense. Direct prevention activities are specific to substance abuse, whereas indirect activities focus more on general issues that are correlated in some way with substance abuse. So that would be things like stress management, assertiveness training. Some of the most effective prevention programs don't mention drugs at all because they help people to build resiliency, which is incredibly important. Okay. And we can also extend this not just to substance abuse prevention programs, but suicide prevention awareness programs as well. Okay. Right. The other thing that we need to look at is the distinction between distal variables, which are the family socioeconomic status, and proximal variables such as peer pressure. And that's because both parent and peer behaviors have been found to correlate with adolescent substance abuse. The development of functional families, appropriate parenting skills, and satisfactory parent-child relationships proceeds and contributes to peer relationships. Thus, prevention programs targeting parents would have delayed effects, and peer-oriented programs would have much more immediate effects on the use and abuse of substances. And again, this is also very population-specific. So looking at evaluating programs, which can be very tricky, and again, going back to we have to have the time to figure out if it's been effective or not, and how are we measuring it? That's very important. There are several issues that are important here. Evaluation as a social judgment process, the relationship between what is desired, what is intended, and what is actually accomplished, the contrast between immediate and delayed effects, and the strength of the effects, and the concept of declining marginal utility. Social judgment is perception. The data used to support an evaluation are essentially neutral. Decisions regarding what data to collect, how to collect them, and what the results mean involve a variety of implicit and explicit judgments. There may be considerable disagreement among the evaluation research teams. So that goes back to earlier. What are our goals? Are we looking at abstinence? Are we looking at helping people with safe use, etc.? So it is important to figure out how we are measuring things. What is our desired, so what do we want to happen, what's intended, and then what did we actually get. And it's not necessarily a failure thing. You could have some really awesome unintended consequences, and so that's where it's really important to figure out what are we measuring, how are we measuring it, and not just quantitative data, but qualitative data is really important as well. Do we have immediate effects? And is that what we're looking for? Are we looking for delayed effects? And then that gives us an issue with how are we measuring these? We know it's very difficult to chase down participants years later. There's always an attrition rate. Okay? So there are other ways to look at, we can look at demographics, we can look at crimes that were committed, etc. Right? So we have a lot of macro level social work going on here. Okay. And then we have to look at statistical significance, which is less likely to occur when either the effects of a prevention program are small or the number of units of analysis is small. So it's just like with any research, we have to figure out, is it generalizable? Because what might work with one population isn't going to work in another area. And then we have marginal utility. And according to this concept, the less the discrepancy between an actual event and the maximum occurrence of the event, the more difficult it can be to change the event. So that means if the prevalence of substance abuse in a community is much higher than the endemic rate, which means the minimally attainable rate, it's relatively easy to reduce the prevalence. As the prevalence decreases, however, it becomes increasingly difficult to further reduce the prevalence rate, and further reductions will require increased resource allocations, right? So basically they're saying we get to a point where the numbers aren't making sense and then it's a little bit difficult to actually implement programs because we're getting to a number here where like, well, endemic means it's already occurring, right? So an epidemic means there's a pocket that happens and we're seeing increased use like we have right now versus something that is endemic, it's already there, if that makes sense. So we talk a lot about this in the policy class as well. Mass media programs like this is your drug on brains. This is your brain on drugs, right? Economic controls like putting taxes on things like cigarette tax, alcohol tax, right? We have more of that. It's not uncommon to have taxes that then go to rehabilitation programs. Mass media programs are very similar to education-based programs because they increase awareness, but it's like, drugs are bad, don't do them. Okay, that's all the information you get. So there's no follow-up. The pro is that it gets the message out there, but then that's it. There's no follow-up. We have DARE. By itself, it's not completely effective. Your authors argue that when these programs are used in conjunction with one another, we have a much higher rate of success. Okay? So they would say, just say no and refusal skills for DARE, but it's also a lot of, ooh, we're bringing all the drugs on the case to school. Look at the shiny drugs. Don't touch them. You'll ruin your life. Okay, so we need to couple that with something else. Legal restrictions, what's against the law, and then decriminalization versus legalization versus you have a little bit of weed on you versus you have a trunk packed and you're obviously a kingpin. Okay. Parenting programs. There's been some research and it's kind of substance dependent. Parenting programs have been helpful with marijuana specifically, but other than that, the authors of the text that we use in the 402 class actually say that they're pretty ineffective. Okay. It can be good to have discussions and a didactic, conversation. However, it really seems to be substance specific. So outside of marijuana, they're not too helpful. Community-based programs would be something like the YMCA, and these programs usually incorporate educational content with assertiveness and maybe team building as well. Drug-free workplaces are becoming more and more common, and tobacco-free places are becoming more and more common. Health departments often will want to swab your fingertips to see if you have nicotine, and they won't hire you until you sign a tobacco-free pledge. Okay. The Center for Substance Abuse Prevention. This is on the SAMHSA website that was published in this week's Moodle module. They identify different areas here. We have to assess, we have to figure out if we have the capacity and what can we do with the resources that we have. We have to plan it, we have to implement it according to our planning, and then we have to evaluate it.